Hello, and thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the raised hand option in the Zoom menu. The public slide deck will also be made available on our website under the Education tab. I will post the link in the chat along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. And in particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for upcoming LHS events, our next Impact seminar will take place on Tuesday, November 7th, with Doctors Amanda Borski and Michael Harrison, researchers at the VA Office of Research and Development and Agency for Healthcare Research and Quality, respectively. With that, I will turn it over to Dr. Bronwyn Southwell to introduce our speaker.
Thanks, Stephanie. It's my distinct honor to introduce Dr. Stephen Dehmer. Dr. Stephen Dehmer is a PhD and senior research investigator and health economist at the HealthPartners Institute based here in Minneapolis. His research is focused on the economics of disease prevention with an emphasis on cardiovascular disease, diabetes, obesity, and cancer. Using microsimulation modeling, he led the decision analyses conducted to support the U.S. Preventative Services Task Force recommendations for aspirin, which were published in 2016 and again in 2022. Dr. Dehmer's current and past research has been funded by the National Institute of Health, Center for Disease Control and Prevention, Patient-Centered Outcomes and Research Institute, and the Agency for Healthcare Research and Quality. His research has been published in leading journals such as JAMA, Nature, Annals of Internal Medicine, and the American Journal of Preventative Medicine. So with that, please join me in welcoming Dr. Stephen Dehmer.
Well, thank you very much, Dr. Southwell. It's a very nice introduction, and it's a tremendous pleasure and privilege to be here with you today. Again, my name is Steve Dehmer. I'm a senior research investigator and health economist at HealthPartners Institute. I'll briefly start with disclosures. Again, I'm employed at HealthPartners Institute. I'm also a graduate of the University of Minnesota. And my research portfolio has been generously funded entirely from or by federal and not-for-profit sources. So I have no conflicts of interest to report, and I come before you here as a public domain academic researcher who is embedded within a healthcare organization. So to move to the agenda for today, that's really the frame that I want to use for today's talk. I'd like to share with you, and then I hope we'll have time to discuss some of my musings on economics and value in a learning health system. Again, coming as a health economist engaged in applied and health services research for nearly 15 years in a research enterprise that is embedded in a large healthcare organization. So topics I plan to cover include why we might conduct health economic analyses. I'll describe and share some examples of some of those analyses, and then spend a little bit of time discussing topics like measuring costs and value. And I don't want to pretend that I'm an expert on all the topics that I'll present, so I really hope that we can also use the opportunity to learn from each other today. Before I dive in framing this talk around my experience as an embedded researcher, I thought it might be helpful to briefly describe the organizational environment in which I live. And I'm sure many of you are aware, HealthPartners is a fully integrated, not-for-profit healthcare organization based in Minnesota. By fully integrated, I mean that HealthPartners includes both health insurance and clinics and hospitals in which patients receive care. And in addition to being a nonprofit, HealthPartners is consumer governed, and I think it's the largest or one of the largest such health organizations in the country. And by that, I mean that the board of directors includes patients and health insurance customers. I like to tell people, think credit union for health care and insurance. The HealthPartners Institute was established over 30 years ago as a nonprofit public domain research organization embedded within the larger corporate structure of HealthPartners. But we have our own board of directors, and our current mission includes research, evaluation, and education. So I want to start off with this quote from Stephen Landsberg. In the opening line of his book, The Armchair Economist, he says this: most of economics can be summarized in 4 words. People respond to incentives. I like this quote because I think it is essentially true and reflects that economics at its core is a behavioral and social science. So while economists might get caught up in complex analyses or measuring costs, and we'll look at some of those examples today, they're usually doing so in fundamental service of understanding what is driving behaviors or decisions, or how incentives may be aligned to lead behaviors and decisions to optimal social outcomes. Economics is hardly the only discipline focused on behaviors, but this is the perspective I'll kind of focus on today. By the way, I also really highly recommend this book. I used to use it when I taught introductory economics. It has sort of a zany approach to explaining economic principles in a fairly entertaining way. And it's not as well known as some more recent books, but it's very accessible and thought-provoking. So let me start with why health economics. What can health economic analyses do to support a learning health system? Well, here's some of the reasons I could think of. First, economic analysis can help facilitate the generation of higher value in healthcare, whether that be by informing better health outcomes or similar outcomes at a lower cost. Economic findings can also help motivate, again, remember responding to incentives, motivate the dissemination and implementation of new strategies, interventions, and care models that may yield better outcomes. Economics can also be used to inform public policy, whether it be with respect to issues of population health, affordability, or access, or even the value of obtaining new information or evidence. Economic analyses can also help guide the stability and sustainability of organizational missions, whether they be for-profit or not-for-profit in orientation. And finally, economic analyses can help to inform priorities in a world full of scarce resources. So those are many of the whys. Now I want to talk a bit about the how. There are many different types of health economic analyses, but I thought I would describe some of the more common ones, and then I'll have some examples to go with these. So let's start with a straight cost or utilization analysis. Imagine, for example, that you might be evaluating a new healthcare intervention that has promise for effectiveness, but may face barriers to adoption if its effects on health care utilization or costs are not known. So you might, as a second or third aim of your study, include a cost analysis that effectively adds medical expenses or healthcare utilization as an additional outcome. Cost effectiveness analyses are also quite popular, and there are several different types. All measure the costs of an action or intervention in monetary terms. That is, for us, usually in US dollars and cents, but the benefits or outcomes are measured differently. A traditional cost effectiveness analysis, or I like the term cost consequence analysis, measures the benefits or outcomes in natural units, such as the cost per millimeter mercury reduction in blood pressure, or the cost per infection avoided, so forth. A cost utility analysis combines benefits, for example, lower mortality risk and lower risk of having a heart attack or stroke, into a composite measure. Usually this measure is quality adjusted life years, or QALYs, which can be used to combine both the life lengthening components and morbidity reducing benefits. So the trick with these analyses is usually in how you can measure comparable quality of life reductions for non-fatal outcomes. So for example, what is the loss of quality of life associated with having a stroke, or for being hospitalized with heart failure, or even for taking a pill every day? But if you can figure that out, the advantage of these analyses, however, is that you can comprehensively measure disparate benefits or even harms of an intervention in a way that can be comparable across other interventions or actions. A cost benefit analysis, or sometimes called benefit cost, measures benefits in a composite monetary measure. So in this case, you might add up the dollar value of prevented heart attacks and strokes and then compare it to the upfront investment. ROI, or return on investment, is another popular type of analysis that calculates the rate of return on an investment. Fundamentally, this is equivalent to a cost-benefit analysis, except for the return is calculated as percentage rather than the number of dollars returned per dollar invested. Finally, and not least in my eyes, is forecasting and simulation modeling. This is an area that a lot of my work has been concentrated in. And specifically, I've led the development of a microsimulation model for cardiovascular disease that we use to project long-term health and economic outcomes related to cardiovascular disease prevention strategies. These models can contain extensive amounts of data from a wide range of sources that allow us to predict, even at an individual patient level, the natural history of risk factors and disease outcomes over time. So with this, we can essentially run virtual randomized controlled trials in the computer where we can have a usual care arm and then compare it to another arm exposed to an intervention, compare the outcomes. What is unique in this case, however, is that each individual is their own control, and we can control the variability in outcomes solely based on the factors directly related to the intervention. Much of the application of that modeling has been applied to public policy issues, such as what are the projected long-term impacts of FDA's voluntary guidance on sodium reduction in the commercial food supply, or in informing clinical guidelines like we did with aspirin for the U.S. Preventive Services Task Force. But there's another application of these types of models that I think strongly complements research within a health system. And the example here is that many clinical trials are too short to observe the most impactful outcomes, such as heart attacks, strokes, cancer incidence, mortality, but they observe important intermediate outcomes like improvements in blood pressure or better management of hemoglobin A1C or higher screening rates for cancers. So simulation or forecasting models can then be used to predict the potential long-term and broader population impacts of an intervention found to be effective on the intermediate outcomes. This, of course, is imperfect, and it's no substitute for a real clinical trial, but many times a 10 or 20 or even 30-year trial would be infeasible or even unethical. So we've found this to be a successful, a nice addition as a second or third aim to pragmatic clinical trials. Before we transition to some examples, I want to briefly say a few words about analysis perspectives. Going back to that people respond to incentives quote, it's important to consider who is responding and what the potential incentives guiding their behavior are. In other words, what is the perspective of the stakeholder in which an analysis may be informing decision-making? There are two broadly applied perspectives are the health system perspective and the societal perspective. With the health system perspective, we're thinking of stakeholders within a health system making decisions, such as whether to pay for treatment or whether to invest in delivering a specific care model or clinical intervention. In these cases, we usually focus on the medical costs paid by health insurers or patients, or on the costs that may be incurred by a care delivery system. I'll show some examples of that later. The societal perspective is the most expansive, and it attempts to capture all the costs and benefits experienced in society, including non-monetary outcomes like the time involved for patients or caregivers, or even opportunity costs such as lost productivity inside or even outside of the workforce. This full societal view is often quite important, but sometimes it isn't particularly relevant to the individual actors making decisions, such as a health insurer or a clinic or a hospital. So this is why we consider both. Okay, so I'd like to now show some examples of some of those different analysis designs that I described. And the first several examples are going to relate to an intervention developed by a team at HealthPartners led by Dr. Karen Margolis, designed to use remote telemonitoring of blood pressures and outreach from pharmacists to help patients struggling to control their hypertension. And the context for this intervention is big. About 1 in 3 adults in the US have hypertension, and only about half of those patients have their blood pressure under control. So to address this, the team developed and evaluated an intervention, which they called Hyperlink, that combines telemonitoring of blood pressure. So a patient takes their blood pressure measurements at home and then sends those readings back to their medical record by the internet, for example. And then there's outreach from a medication therapy management or MTM pharmacist to assist with lifestyle or medication issues that may be undermining the achievement of blood pressure goals. In a randomized controlled trial, Hyperlink was found to significantly improve blood pressure control by about 18% and to reduce systolic blood pressure by almost 10 points over 12 months. So this finding raised a number of practical economic related questions, such as how did Hyperlink affect healthcare utilization? Is Hyperlink cost effective? What is the ROI from Hyperlink over 5 years, for example? What would the health and economic impact of an intervention like Hyperlink be if it were implemented nationwide? So let's take a look at some of those questions because we've addressed all of them. The table on the slide here shows the result of a medical care and cost utilization study that we conducted for the patients participating in the Hyperlink trial. Specifically, we compared changes in medical care costs before and after study enrollment between the intervention and usual care arms. So, for example, we found that the mean total medical costs were $86 lower on average in the 12 months after enrollment compared to before in the Hyperlink arm. In the usual care arm, total costs were $96 higher on average. Thus, patients in the Hyperlink arm had a change in medical care costs that was $281 lower on average compared to the usual care group in the 12 months following their enrollment. This overall result was not statistically significant. There were some other interesting patterns, though. For example, pharmacy costs were about $82 higher per patient in the intervention arm, and that difference was statistically significant. This makes sense because the intervention was designed to help address issues with medication adherence, so a greater cost of medications is expected. We also saw meaningful reductions in CVD-related hospital costs of about $500 per patient on average with the Hyperlink intervention. This result wasn't statistically significant, but you can see that there was a slight trend. So these findings make sense overall, I think, and should be informative to implementing Hyperlink more broadly. Within 12 months, from a payer perspective, we could expect some medical expenses, such as for medications, to rise, but these may be offset or potentially offset by other averted expenses elsewhere. Next, I want to address the cost effectiveness of Hyperlink. First, we found that it cost about $1,350 per patient to deliver the Hyperlink intervention over 12 months. When accounting for no significant change in healthcare utilization over that period, we found that the average cost was about $7,000 per patient achieving blood pressure control. Or if we include the non-statistically significant $281 reduction in total medical costs over 12 months, that would fall to about $6,000 per person. Or it would be closer to $8,000 per person if we included the increase in pharmacy costs that were statistically significant. We could also do this for other outcomes, such as the cost per millimeter mercury reduction in blood pressure. And here we found that it was about $139 per unit reduction in blood pressure, which then can be compared to other interventions that have also been effective in reducing blood pressure in this type of population. With this next example, I want to address ROI and cost benefit of Hyperlink over 5 years. In this study, we were able to do a 5-year follow-up of the study participants and found very large effects on CVD outcomes. Specifically, we found about a 50% reduction in new CVD events for Hyperlink patients compared to their control group, though this difference wasn't quite statistically significant. This was also a much larger than expected benefit. When we projected out the reduction in CVD events using our simulation model on the basis of blood pressure reduction alone, we estimated closer to 10 to 15% reduction in these events over 5 years. In any case, we attached costs to these events between the two arms and accounted for the upfront investment to deliver hyperlink. Here it was about $1,500 per patient when accounting for inflation. And what we found was an 82% return on investment, or an annualized return of about 13%. The other way to see this result is with the benefit cost ratio, which tells us that for every dollar invested in delivering hyperlink, that $1 plus 82 cents was returned. Either way you look at it, this is a fairly compelling investment, and it looks even better when accounting for secondary endpoints like revascularizations. Finally, in collaboration with partners at the CDC, we have a couple studies where we've looked at the potential impact of implementing interventions like hyperlink nationwide. We used our cardiovascular disease microsimulation model to project outcomes over 10 years for patients with uncontrolled hypertension nationwide. We assumed that the intervention was slightly less effective than was true for hyperlink, but also less expensive to deliver. And we found that this intervention, when delivered nationwide, could improve hypertension control rates by about 10% over 10 years and result in nearly 5 million fewer persons over blood pressure targets. Moreover, we estimated that the intervention would result in about 31,000 fewer myocardial infarctions, 204,000 fewer strokes, and more than 600,000 fewer CVD events. Now, if you're familiar with the Million Hearts campaign, here is a single intervention that could go a long way towards that goal of reducing 1 million heart attacks or strokes. With respect to costs, we found that the total cost of the intervention would add up to $23 billion, but this would be offset by a $25 billion in averted medical care costs. So from a societal perspective, in addition to all the health benefits, this intervention would be cost saving by about $2 billion. What is interesting, though, was that we estimated about $6 billion in the net cost savings would go to Medicare. In effect, private and other insurers would make the upfront investments in delivering that intervention, and then Medicare would later yield the benefits. Here again, this is a classic case in which relating to responding to incentives, where although society could benefit overall, private insurers and others payers may not be willing to invest in paying for this service if they don't get back sufficient benefits, which could then result in a suboptimal societal outcome. Hence, there may be room for public policies that align incentives to be able to realize those overall societal gains. Next, I want to share an example about using economic modeling and forecasting to help inform priorities among clinical preventive services. Here's the context. The Affordable Care Act established insurance coverage for all A and B graded preventive services recommended by the U.S. Preventive Services Task Force. These recommendations are always changing, but there are a lot of these top recommendations ranging from the primary prevention of cardiovascular disease, tobacco cessation, cancer screening, and also vaccination programs. Several studies have looked at the clinician workload related to these recommendations and have found that it would take a typical clinician between 7 and 14 hours just to deliver just the recommended preventive services to their patients. That is, before you have time for chronic or acute issues or whatever the patient, their primary reason for the visit was, just doing the recommended screening and prevention would take at least 7 hours a day. In other words, there isn't enough time to do it all. It's just not possible. So if you can't do it all, what do you do? Well, under the direction of the National Commission on Prevention Priorities, we set out to consistently and comparably estimate the population health impact and cost effectiveness of 28 top recommended clinical preventive services. This slide shows part of our ranking, which sorts preventive services on the basis of the two metrics I just mentioned, the clinically preventable burden, which is another way of saying total health, population health impact, and cost effectiveness. Each domain is scored from 1 to 5, with 5 being the highest, and then the 2 scores are added. And as you can see, childhood immunizations and then screening and counseling youth and adults for tobacco use were the highest ranked, with top scores in both of these domains. They all have high expected health impact, and all 3 of these were found to be cost saving as well. Not too far down the list, you'll find aspirin counseling and then cholesterol and hypertension screening in that order. To the right in the table, you can see some more detailed results from our modeling study. Aspirin had a lower potential health impact with a preventable health burden of under 100,000 QALYs in a 4 million person birth cohort, compared to over 500 or 600,000 QALYs for cholesterol and hypertension screening. But aspirin for primary prevention was also cost saving, which was influential in its overall ranking. Of course, you could assess these, just on health impact, and the ordering would be different altogether. Further, I would note that these findings are now obsolete for aspirin with the new recommendation and new evidence that has come out since we did this analysis, and certainly would change things. On the lower end of the list, there's an example of obesity screening for children and adults. And here's a case where the potential health and health impact is large, but the cost effectiveness is low. And this is because the effective obesity screening and management tends to be very resource intensive. And at the very bottom of the list was the Tdap TD booster, which scored lowest on the total population impact and cost effectiveness. Now, this is, of course, relative to other services, and all these services are found to be clinically effective. I'm not sure how influential these rankings are currently, and we found it hard to find consistent funding to keep them updated. But we used to have at least a running list of examples where care systems had used this kind of information to align incentives with the highest value services. Okay, now I'd like to transition, take a little break from examples and share a bit about methods for measuring costs. I can think of at least 3 approaches. The first is to use charges or list prices. These are the prices that a hospital or care system may say something will cost, but the problem is that they rarely represent the actual price paid. Instead, charges or list prices are typically wildly inflated and wildly inaccurate. So if you're going to use them, you might be advised to discount them first, for example, by estimating that 50% of a charged amount is close to the price actually paid. But even this is likely to be inaccurate. A second is to use actual paid amounts. This method does not suffer from the list price inflation, but paid amounts are still potentially problematic because they can be very specific to a point in time, place, or insurance product. So, for example, an insurer might have a different negotiated payment rate with hospital A versus hospital B, and they might be providing the exact same service, but one could look more resource intensive just based on the negotiated price alone. Or you could have patient A and patient B having the exact same service at hospital A, and they may even have the same exact insurance company, but they have different insurance products that reimburse differently. Hence, if we want to measure actual differences in medical care use, we likely do not want that pricing variability to interfere with that assessment. And this leads me to method 3, which is generally preferred, and that is to use standardized costs. For this approach, in every case that a patient had a specific type of clinical visit or procedure, we apply the same cost. This way, the costs reflect a difference in the underlying utilization or resource use, rather than being confounded by pricing differences. There are several approaches to doing this, such as using CMS relative value units, or RVUs, average wholesale prices for medications, or an approach I'll be saying more about, which was happened to be developed at HealthPartners, called Total Care Relative Resource Values, or TCRRVs. Here's a more visual explanation of how standardized costs work. Basically, you can measure the resource use, which could be measured in RVUs, billed services, hospitalizations, or dispensed medications, and then you apply a fixed price for that resource, and you multiply it out. So let me tell you a little bit more about TCRVs. These were developed about 20 years ago by HealthPartners as a part of their methods to measure the total cost of care. They use a variety of data sources to calculate them, including Medicare RVUs, claims, and pharmacy data. They include outpatient and professional services, hospitalizations, and medications. And this is kind of a big deal because many services like labs are excluded from the CMS RVUs. Further, they're designed to be consistent and comparable between and within domains, so you can use the same methods to compare outpatient costs with pharmacy costs, for example. And they're also pretty simple to apply, as a TCRRV weight is the equivalent of $1. They're freely available for researchers and organizations, and they've also been endorsed by the National Quality Forum. Now, I realize this might sound like a little bit of an infomercial, but I actually have no direct connection to the teams that develop these tools. And I don't think that HealthPartners generates any revenue from sharing them with the community. So I'm speaking mostly as a user here who happens to work at HealthPartners, but I think these are pretty cool. And I'd encourage you to check them out if you're unfamiliar. There's a link in the slide where you can learn more. And just to make this more tangible, I thought a few worked examples might be helpful. Here you can see an example of a patient with 2 clinic visits, one in January 1st, one on March 1st. The January visit included a level 3 office visit with a clinician. And this is a moderate complexity visit, and also a flu vaccine. On the right side of the table, you can see that each of these CPT-4 codes for these services has an associated TCRRV of $187.78 and $37.56, respectively. The March visit included a level 4 or a slightly more complex visit with labs for a metabolic panel, hemoglobin A1C, and a complete blood count. Each again have an associated cost, and you'll notice that the level 4 visit is about $80 more expensive than the level 3 visit. At its simplest level, this is really all that's involved. Matching a CPT-4 code with a TCRV, and you get the cost. You can do more sophisticated things like with risk adjustment, but this gives you a sense of how easily they can be applied. Next are a couple quick examples of inpatient and pharmacy costs. At the top table are diagnosis codes for hospitalizations. One's for a knee replacement surgery and another for a major cardiovascular procedure with complications. The knee surgery has a 2-day length of stay, and the cardiovascular procedure has a 3-day length of stay. Costs for the hospitalizations are distinguished day 1 from subsequent days. So for the first day of a knee procedure, that costs about $28,000, whereas each additional day at the hospital costs about $149. The cardiovascular procedure has a higher first day and cost for subsequent days. But to calculate the cost, you just have to take the first day cost plus multiply out the additional days to get an estimate for the total cost of that hospitalization. For medications, the TCRVs are linked to medications defined by the National Drug Code. The cost is for each pill. So a 90 count fill of lisinopril at 21 cents per pill will have a cost of about $19. So and so forth. I think you get the idea. The bottom line is that this is a freely available toolkit that I think you might find helpful in doing LHS evaluations or studies. Okay, now I'd like to transition to a new topic on measuring value in a learning health system. And I want to start with what I will call a big L learning health system. In other words, what if our entire health system embraced a learning model? What are the potential benefits? Well, first and foremost, we could anticipate through a variety of mechanisms that this could lead to improved health outcomes. So things like longer life expectancy with more healthy days, better well-being, so forth. Second, we might hope that this leads to lower costs. Value-based care typically indicates achieving the same health outcomes at a lower cost or better health outcomes at the same cost, or at least this relationship between outcomes and costs is the metric under which value is defined and measured. A lower cost for health and medical care means more income and public dollars that can be allocated elsewhere. So for individuals, this might mean saving more money for retirement or for taking vacations. And for the public sector, this might mean things like more money for investing in education or infrastructure, or even for lowering taxes. We might also see greater access to care with better and more stable coverage. These are intrinsically valuable, but can also confer other benefits. Reliable access to healthcare can improve health outcomes, establish greater investment in prevention, and free a person or a family to focus their attention on other valuable and meaningful endeavors. A big L learning health system may also have better overall satisfaction with healthcare. Patients and insurance members will have more positive experiences, perhaps through more patient-centered, simpler, and more streamlined care. I'm not sure exactly where healthcare currently ranks in consumer satisfaction. I'm guessing it's above cable companies and Congress, but I suspect that we could find many other countries in which satisfaction and experience with healthcare is better than in the US. I think there's room to grow. We might also hope for a health system that is more responsive and that can react to and adapt to needs and emergencies as they arise, such as a global pandemic, for example, hypothetically. In addition, and finally, a high functioning and learning health system should have a broader and faster ability to faster diffuse and disseminate best practices. New knowledge and innovations could be rapidly and consistently adopted across the system. Now, it may be tricky to put a monetary value on each of these items, but I think they all reflect value at a societal level. Next, let's consider the value from a little L learning health system. By this, I mean the perspective of an individual care system, health insurer, or organization. Some of the features intersect, like better healthcare outcomes, lower costs, higher satisfaction, but they operate a little bit differently. Improved healthcare, improved population health outcomes can mean higher quality ratings, can also make a care system more attractive, or they may also yield incentives for meeting contract goals like with an affordable care organization. Lower costs can mean better affordability and maintaining competitiveness in a marketplace and attractiveness for inclusion within insured networks. This can also result in enhanced financial stability for an organization. Both improved outcomes and lower costs and other innovations can result in higher satisfaction with care and services. This could mean higher consumer affinity. Being adaptive and learning can also result in a more robust, resilient, and innovative business model, further fueling market differentiation and competitiveness. Finally, there is an enhanced marketing value of these activities. With high-profile research comes heightened prestige and name recognition. This in turn can help to attract and retain patients and customers. It can also serve to attract and retain clinicians and faculty scientists and staff because people generally like working for organizations with strong positive reputations. And this can sort of create a cycle. Attracting top doctors and researchers can lead to more prestige, and that in turn can attract more patients and more top talent. So it can become a bit of a cycle, and it can also help to establish and permeate a positive organizational culture. So these are just some of my musings on this topic, which I've been thinking more and more about lately, but I'd really love to hear your thoughts. I'll also pose the question of whether a bunch of little L learning health systems doing all these things can add up to a big L learning health system. And I would say as an economist that I think I have to believe this is to be true. Even if each care system is potentially selfishly doing all these things to serve their own self-interest, that doesn't mean it cannot amount to socially beneficial outcomes. Competition can be very good if the incentives are aligned correctly. Each organization trying to do the best for themselves can also end up doing the best for the whole. Now, perhaps this is an overly optimistic view, but I think it's an important question to think about. Again, would really love to hear your thoughts. But before we get to that, I have two more examples of economic analyses designed to estimate value, one from a little L LHS perspective and one from a big L perspective. Let's start with a little L perspective with a potential business case for implementing a clinical decision support system. My colleagues at HealthPartners Institute have developed and evaluated numerous clinical decision support systems over the past 20 years. Currently, all HealthPartners and Park Nicollet clinics have a clinical decision support system called the Priority Wizard, which helps to alert and engage clinicians and patients in shared decision-making around opportunities for cardiovascular risk reduction, with priority given to actions that would have the largest benefit in reducing risk for future cardiovascular events. We took advantage of one of these randomized controlled trials to evaluate the effect of this decision support system on how each clinical encounter was coded in terms of its complexity. Clinical visits can range in complexity from 1 to 5, and as we saw earlier, higher complexity visits can come with higher payments. The table in the upper left shows these 5 levels and how visits were proportionally coded in clinics with CDS versus clinics with no CDS. Note that the CDS clinics were more likely to have slightly more likely to have level 4 and level 5 visits, which is offset by fewer level 3 visits. The visits would be classified as higher complexity because more time was spent addressing clinical issues, such as those identified by the CDS. So for example, this might be tobacco cessation or addressing uncontrolled blood pressure. When comparing the reimbursement for 1,000 visits with these slight differences in coding, that we estimate that would amount to about $7,500 in reimbursement, additional reimbursement. Oops. Imagine that you are running a care system that has 100,000 visits per year that would be able to use this decision support system. The annual revenue gain would be about $750,000 then, resulting from those more intensive clinic visits. Suppose also that it would cost you about $500,000 to implement this system and an additional $100,000 per year to maintain it. The discounted net revenue over 5 years would be $3 million. The ROI over that 5-year span would be nearly 350%, or a 35% annualized return. In other words, for every $1 invested, $3.50 would come back. Now, this seems like a pretty good deal to me. Even if you had to borrow the funds for the investment in that clinical decision support system, say at a 5 or 10% interest rate, the return on that investment would far exceed the cost of borrowing that capital. Moreover, while this might look like a self-serving revenue-generating move by a care delivery system, the extra activities being paid for have value. A patient who quits smoking or improves blood pressure control is less likely to experience adverse events and their associated costs. So if we looked at this at a perspective from a payer or a patient, I think they would see it as being beneficial as well. Again, even self-interested behavior at a micro level could still potentially result in substantial societal benefits. Lastly, I have an example related to the potential value of more research. This example draws from an NIH workshop and an evidence report from last summer on oncology nutrition services. And the evidence report was actually conducted by a team here at the University of Minnesota and the Minneapolis VA. Here's the context. There are 18 million people in the US with a history of cancer, and there are about 1.75 million new cases of cancer each year. The associated cost with cancer is about $183 billion, and this is projected to increase another 30% by 2020. The initial cost of a cancer diagnosis is associated with about $42,000 on average, and then there's an additional $5,000 typically after the initial treatment. And then there's an average $100,000 spent at the end of life phase. Meanwhile, an estimated 25 to 70% of cancer patients are affected by malnutrition. Malnutrition leads to weight loss, frailty, and serious conditions like cachexia and sarcopenia. These conditions can in turn lead to decreased treatment tolerance, lower treatment adherence, reduced quality of life, greater lengths of hospital stay and readmissions, and greater mortality. All of this would suggest a potentially strong economic case for nutritional interventions, but the evidence is still lacking. The evidence report found major gaps in quality evidence, particularly from randomized controlled trials on nutritional interventions for cancer patients. So where do we go from here? Well, I created a really simple little forecasting model to illustrate the potential cost impacts of screening and treating cancer patients for malnutrition. Here's how it goes. Suppose that all 1.75 million new cases of cancer include nutritional screening. Based on the CPT-4 code for this service and the associated TCRRV, this would have an estimated cost of about $77 per screen, or about $134 million per year. Now suppose that about half of those screened go on to needing ongoing nutritional counseling. Let's say there are 4 sessions and they cost about $66 a piece. That amounts to another $230 million. Now suppose that 10% of the council patients require hospitalization, but their length of stay is 3 days shorter than it would have been otherwise due to their improved nutritional health. That would avert about $61 million in spending. Further, suppose that just 1% of the patients who were counseled were able to avoid a hospitalization due to better nutrition. Suppose that those hospitalizations are about 16 days long and cost about $85,000 on average. That would avert another $750 million in spending. Altogether, almost $500 million of medical expenditures would be averted with a net savings of about $250 per patient screened. Now, these are somewhat, but not entirely made up numbers, and maybe they're even conservative. But if a healthcare system could save nearly $500 million every year by screening and treating for malnutrition in cancer patients, I would hope it might be worth to NIH to invest in a few R01 awards or other funders for that matter to support research to shore up the evidence to confirm or deny these potential benefits. And I'm actually working with some colleagues to improve on the quality of these very rough estimates to try to evaluate the potential monetary benefits of further research in this area. And with that, at a pretty brisk pace, is all I wanted to share. Thank you so much for the time, and I really look forward to any questions you have and discussion. Thank you.
Wow, thank you, Dr. Dehmer. We have a little over 5 minutes remaining for Q&A. If you have questions or comments, please, you can raise your hand or put them in the chat or the Q&A, Zoom Q&A. And yes, Rowan has a question.
Yeah, thanks. Dr. Dehmer, that was really amazing. Thank you so much for your time and speaking with us today. I am really interested in the last point and project you described with the oncology nutrition interventions. And I have a question about how you came to the cost savings and if you looked at the incidence of surgical complications, specifically surgical site infections is one area that I'm interested in. And I've come across quite a bit of evidence showing the decrease in surgical site infections, specifically in the malnourished populations of oncology patients. I've seen some estimates up to 60% decrease in SSIs with a nutrition intervention for that population specifically. So I'm wondering if that was included in your analysis at all.
It was not included, so which is why like it could be conservative. I mean, there's somewhat made up numbers, but there are a lot of things we didn't account for, and that's a good example of one. We're trying to do some refined estimates of this using literature informed estimates of data where we have it, particularly for head and neck cancer patients, thinking that's a pretty good population to assess nutrition screening on. So there's more work going, but I thank you for that comment. That's really helpful to hear.
We have a question that healthcare economics related with disease burden closely. When you analyze your study, do you adjust the disease burden factor?
Let me look at that question. Well, usually we do. I mean, it depends on the analysis, but when we're looking at outcomes, for instance, the burden of a heart attack or a stroke versus maybe like a GI bleed, for example, they may have different burdens on quality of life, different case fatality rates, and so we do try to account for that wherever possible. I hope that gets to that question.
Great. We have time for a couple more questions. In the meantime, Dr. Dehmer, thanks again. What would you say is the most important takeaway for our audience?
Gosh.
No pressure.
Well, yeah, hopefully this is interesting. I know that there's a lot of work that goes into effectiveness or efficacy of different strategies, innovations, interventions, and so forth. And I would just encourage, to consider also costs, including costs as an outcome, or looking at downstream outcomes, because it's often a question, if you find something is effective, when you get to the stage of translation and dissemination, those questions arise. So designing studies and evaluations that are looking at those can often be helpful to ensure that these innovations actually get adopted and don't just kind of be discovered, but then never really implemented.
Yes, Genevieve.
Steve, thanks so much for your talk. It was great, really, really great. A lot of both just things to think about in the future, but also really, really some great practical things. I'm curious about that piece around translating your work directly with healthcare systems or practices. And any tips you might have around that. It feels like often, when we're trying to decide whether or not to do something within, say, a health system or a practice, the business case and putting that together up front is so important, and often is something that folks just want to get through really quickly. They just want to get that initiative in, and just curious about any advice you'd have around that.
Yeah, it's tricky. I mean, there's a different timeline often between research or even evaluation and those making decisions and wanting to get things on the ground. And also, impatience for that evidence, and also impatience for, the business case information. And I experienced that, trying to all right, let's ground our assumptions and try to use as much data as we can to inform things. So I think that tension is always there. I don't know that I have a magic solution for it, but I think being intentional about designing evaluations and studies to include those, getting those decision makers at the table early in the design phase can be really important as stakeholders, to make sure that some of those considered, because sometimes it's like, oh, well, we could have done that had we realized that we needed to measure that or look at that. And it can really help. It'll also help focus in on what the really relevant decisions are in practice, in terms of making sure that the outcomes are going to be most impactful. And I will say, maybe it's a shifting tide over time, but in the studies I've been involved in, even ones where we've got broad stakeholder involvement, even patients, everybody sees the value of looking at costs. Like it's not taboo necessarily. I think it has to be measured and handled appropriately from a big perspective in terms of all those infected and the different ways that costs can be incurred. But everyone's very interested in that and recognizes the value of it. At least that's been in my experience. So I'd encourage persistence in trying to do it.
Great. Well, thank you once again, Dr. Dehmer. And to everyone else, thank you for joining us today. And please join us for our next seminar on November 7th at noon Central Standard Time. We'll be joined by Doctors Amanda Borski and Michael Harrison. This concludes our presentation. See you next time.
Thank you so much, everyone. Please feel free to reach out if you have any other questions or want to collaborate. Would love to. Thank you.